Listen up. We're jumping into the blitz. High-pressure traps are structural killers. Time is critical. Let's move. First trap on the board, coarctation of the aorta. The problem? A critical narrowing, a choke point. Classic sign, you gotta check for it, is high blood pressure in the arms and way low pressure in the legs. You can literally feel it. That's the radiofemoral delay. Now, get your eyes on the chest x-ray. You're hunting for two things, and you need to find them fast. First is the 3 sign. And the second, the pathognomonic finding, is that classic rib notching. Don't miss it. And the key association you absolutely cannot forget is Turner syndrome. Lock it in. Next trap, moving on. Transposition of the great arteries. So what is it? Simple. Aorta and pulmonary artery are swapped. This creates 2 completely separate parallel circuits. It's a disaster. You're looking at profound cyanosis right at birth unless there's a shunt. On the imaging, you're looking for that egg-on-a-string heart. And you've got to connect it to maternal diabetes. The lifeline? It's prostaglandins. You give them to keep that ductus arteriosus wide open. Remember, find the pressure gap, see the notch, spot the egg, save the flow. Let's go. Okay, we are now slowing down. Before we dive deeper into these complex traps, I need to deliver a brief but critically important statement to the entire team. Please be advised, this content is for educational purposes for USMLE and international boards only. It is not, under any circumstances, to be considered medical advice. You must always consult official guidelines and a specialist physician for any and all clinical decisions. All right, back to it. Sarah, coarctation of the aorta is a board favorite for a reason. It's the perfect bridge between anatomy and diagnosis, so break it down for us. Explain the pathophysiology. Why exactly do we see rib notching on a chest x-ray? It's a brilliant, desperate compensation, Dr. Collins. Think about it. The aorta is essentially clamped down, so the body has to engineer its own bypass. Blood is forcefully rerouted from the subclavian arteries into the internal thoracic, then into the intercostal arteries, all to rejoin the aorta downstream of the blockage. Over years, these intercostals become massive, high-flow conduits. Their constant, powerful pounding literally erodes the inferior surface of the ribs, usually ribs 3 through 8, and that erosion is the rib notching we see on the film. Precisely. And that physical finding, the radiofemoral delay, is the clinical echo of that very same bypass you just described. And for the boards, you have to remember the high-yield associations. Turner syndrome, that's 45XO, and a bicuspid aortic valve, which is present in up to a staggering 70% of these patients. Okay, now let's pivot to the true blue baby emergency, transposition of the great arteries. Right. Transposition of the great arteries is a parallel circulation nightmare. The aorta comes off the right ventricle, sending blue, deoxygenated blood right back out to the body. Meanwhile, the pulmonary artery comes off the left ventricle, sending red, oxygenated blood back to the lungs. It's a useless closed loop. Without mixing through a PDA, VSD, or ASD, it is completely incompatible with life. The number 1 risk factor you need to know is maternal diabetes. And the chest x-ray is absolutely classic. That narrow mediastinum gives the heart that infamous egg-on-a-string appearance. Excellent. So that brings us to the critical intervention. Sarah, why is the immediate administration of Prostaglandin E1 an absolute life-saving emergency for these neonates? All right, team. Time to lock and load. Let's burn these high-pressure traps into your memory. On my count. Get ready. Coarctation is the gap. Notching is the map. Dr. Collins and Sarah, Turner is the girl.
Transposition is the swirl.
Egg is the heart. Diabetes is the start. Dr. Collins and Sarah, PGE1 to mix.
Traps locked.
Fantastic work. Now for our question of the day. And this is for everyone out there. Have you ever seen a real-life chest x-ray with rib notching that was so pronounced, so obvious, it just jumped right off the screen at you? You know, it's a rare and classic finding. Go ahead and share your experience in the comments below. We'd love to hear about it. So there you have it. You've just navigated 2 of the most critical structural heart defects out there. But what happens when the pressure dynamics reverse entirely? Well, it's time for the finale. Make sure you subscribe to Clinical Crash Course and join us for our final module, Module 6, Eisenmenger Syndrome and Rapid Review. You don't want to miss it.